Hello, welcome to speaking about Peds and dermatology. We all know that Peds has a lot of skin issues, and so hopefully this will give you a little bit of an understanding behind it. We're going to talk about causes and precipitating factors. We will talk about how to do an assessment, the clinical presentation, signs and symptoms, any comorbidities that could be related to internal issues. We'll talk about diagnostic. We'll talk about emergency care. We're going to talk about nursing interventions, how to develop a home-based plan of care, and alternative therapies. So lots and lots of stuff for this chapter. So when we talk about skin, it's funny, we had a debate on this the other day, but the skin is the largest organ of the body and it has multiple functions. So it obviously regulates your temperature from being normal to hypothermia to being hyperthermia. It works as a barrier to the environment. It works to prevent body fluid loss, vitamin D production. You know, think about when you're out in the sun and you have that vitamin D production. It excretes toxins, and of course it has a sensation of touch. We have the epidermis, the dermis, and subcutaneous layers of the skin that are all critical in the function and integrity. Newborns and infants are really at risk because their skin is thinner and weaker, and also their body surface area for a kiddo is larger than an older child or adult. And then as that child gets older, the skin does take on more adult characteristics such as increase in hair, increase in sweat and sebaceous gland secretions, and thickened texture. So when we do assessments on kids, we want to make sure that you follow whatever tool that your facility utilizes. The most common one is the Braden Risk Assessment Scale, but it is not the other one, and there are actually multiple really good ones out there. So make sure that you understand what your facility uses. When you're assessing the patient before you do the risk, you're going to talk about, you know, what's the general health of the child? How long have they been ill? Has the rash or skin lesion been changing, or has it stayed the same and just not went away? Do they have itching? Have they started any recent medications, even over the counter? Have they had any recent vaccinations? Do they have any allergies, not just to medicine, but to bugs or foods or pollens, or maybe it's the laundry detergent that mom just switched to. So you want to know if there's been any changes in the household. Have they been sick? You know, there's a lot of viral upper respiratory infections that causes rashes. Also bacterial. Think about your strep. It's very common to get a rash with strep. And does anybody else in the family have any kind of similar rash or lesion? When you do the physical examination, what's the distribution or pattern? Is it just in the trunk? Is it maybe just in the hands or in the arms? Is it just in exposed skin? Like for instance, does it cut off where, sorry, you can't see the camera. Does it cut off where the shirt would end and then above the collar? Are the lesions just in the flexure, which is in the anything that flexes, like the knees, the elbows? Are lesions clustered, such as like herpetiform? Are they scattered and are diffuse? Do they follow a dermatome, which is the nerve pattern? You know, think of your shingles. The shingles will go right around, doesn't cross the midline, but it'll go right around where that dermatome or nerve goes. Are lesions in a straight line, which is linear? Are they serpingidous, which is wavy? Are they annular, which is ring-shaped? which, ring-shaped is different than circular. Is it reticulated, such as lacy looking? Is the epidermis involved? So, so does it have scales, papules, vesicles, and pustules? Is a dermis involved? A lot of times, if there's an elevated area, that does mean that the dermis is involved. So like nodules or tumors. What color are the lesions? Are they flesh colored? Are they red? Primary lesions often arise from the skin itself. So these are your macules, your papules, your plaques, vesicles, pustules, wheals, and nodules. Secondary lesions grow out of primary lesions or occur when a primary lesion becomes irritated or injured by scratching. Secondary lesions include crusts, ulcers, fissures, and scars. You do want to check for any systemic signs and symptoms such as like fever, headache, decreased responsiveness, and pain. Purpura. Purpura is a purple or blue lesion that does not blanch. It is an ominous symptom in kids. It can be associated with critical conditions. The most common is bacterial meningitis or can be both, thrombocytopenia. And if you ever see purpura on a kid, you need to notify the provider immediately. In your nursing care, you need to provide cultural competence. A lesion on a light or fair-skinned individual is going to be different than on a dark-skinned individual. So, you need to definitely take that into consideration. Is there any cyanosis? Is there any jaundice? If you are concerned and the individual is dark-skinned or dark-toned, and you're looking for if they're pale or if they're cyanotic or jaundiced, examine the conjunctiva underneath those lower eyelids. Look at the oral mucosa. And then jaundice, if it's really bad, can be observed in the sclera. If the kid is hospitalized, you need to do that constant skin assessment. You need to watch and try to do interventions for prevention of skin breakdown. You need to manage impaired skin integrity. So you want to make sure and be providing care of surgical incisions. You want to document. Make sure you're providing the appropriate care, but as well as documentation so that if a different nurse is on the next day, they can tell if it's getting worse. You want to watch your IV catheters with careful monitoring for infiltration, especially a lot of the meds can be necrotic or can be very damaging to the sub-Q tissue if it does get infiltrated. Remember your maintenance of invasive tubes and probes that have to be taped. Tape can cause skin breakdown, such as, you think about with like Foley catheters, pulse oxes, nasal tubes, and think about on the tip of the nose when you've got a nasal tube that really can break that down. And one of the big things to remember is kids who are acutely or chronically ill are at risk for pressure ulcers. And this is an example of the Braden risk scale. You will need to be familiar with it. And it goes through and, it checks for sensory perception, moisture, activity, mobility, nutrition, and friction and shear. Here are acquired disorders when we talk about pressure ulcers. Multiple skin lesions are the results of acquired disorder from external forces such as pressure, contact with allergic substances, or processes that affect skin integrity. Think of shearing as you're moving that patient up. Treatment for these conditions really does vary significantly, and it does change so much. That's why we have you follow a wound care nurse. Pressure ulcers is the first thing, and the child who is immobile or hospitalized is at high risk. You can often see around the ears from the oxygen tubing. You can see the head, sacrum, scapula, feet. The other, besides immobility, is if they have a comorbid condition affecting circulation, any kind of use of tubes. You want to make sure and stage these. So again, the stage 1 is non-blanchable erythema of intact skin. Stage 2 is partial thickness skin loss with exposed derma. Stage 3 is a full thickness skin loss. Stage 4 is full thickness skin and tissue loss. And unstageable is obscured full thickness skin and tissue loss. Deep tissue is persistent non-blanchable deep red, maroon, or purple discoloration. Again, document, document, document. You want to assess the skin regularly and assess risk factors with the Braden or another appropriate scale. You want to make sure that you're using padding devices like an egg crate, dressings, frequent position changes. You need to assess the patient's pain and treat any infection with dressings and prescribe topical or oral antibiotics. If it's a bad wound, it may need debridement, especially if there's necrotic tissue present. And you will see adjunct therapies used such as hyperbaric oxygen chambers, negative pressure wound therapy like wound vacs, ultrasounds, and electrical stimulation. For home and discharge, you're going to want to educate the caregivers to monitor the wound closely for healing or any worsening. They need to call the provider if there's signs of infection or necrosis. They need to make sure that they're giving medications and dressing changes as prescribed. They need to be able to keep the area clean and dry. And if the patient's still immobile, you want to teach them how to move them and prevention measures to redistribute the pressure and monitor for any worsening or new breakdown of the skin. Dermatitis. The main types of pediatric dermatitis are diaper, seborrheic, contact, and atopic, which is also eczema. So clinical presentation of diaper dermatitis is where the skin around the diaper becomes irritated from chemicals and enzymes in the urine or feces. So the skin really can become erythematous, it can have scaling, but typically it is confined to the convex surfaces that the diaper covers. You can see infection with candida, which is a yeast-like fungus. Anytime you see those have very well demarcated edges. With candida, they can have satellite lesions on the buttocks, legs, and abdomen. And those often differentiate from the milder forms of diaper dermatitis. But your interventions, you're going to put the ointment containing zinc oxide for irritants and nystatin if there's any fungal component or yeasty component. Hydrocortisone 1% cream may be ordered if it's severe. And you're going to want to teach the caregivers to monitor for signs of bacterial infection, such as pustules, purulent discharge, increasing ulcerations, and erythema. You want to educate the parents on keeping the area clean and dry, changing diapers frequently. They're going to clean the diaper area with warm water each time. Think about if they use wet wipes, that can set the baby on fire. If soap is required, you want to do Cetaphil or Neutrogena, Dove. They want to avoid vigorous scrubbing. Again, be very careful with commercial wipes as they can be sensitive to the chemicals in it. Leave the diaper area open to air when possible. And really the recommendations are 15 minutes, 4 times a day. Do not use plastic diaper covers because that holds in heat and moisture. Barrier ointments containing zinc oxide, such as A&D ointment and Desitin. And don't use baby powder or cornstarch because it can get into the infant's lungs. And interesting enough, there's been several studies that say using baby powder can increase the patient's risk of vaginal or cervical cancer for females. I don't know how much I believe that. I wonder if it's more of a that they just noticed at the same time, and it may be more relationshipal and not causative. But we do know baby powder or cornstarch in an infant's lungs is bad. So teach them to avoid that. Seborrheic dermatitis often can be called cradle cap when it occurs on the scalp. You can get it in different places. You can get it on the forehead, you can get it on the eyes, but it usually manifests with scaling and a greasy appearance on the scalp and in folds of the body. It can also be behind the ears. It does not itch. And so that's how you can really tell between seborrheic and atopic dermatitis, because atopic dermatitis itches. And in this picture, you can see the cradle cap here. We don't really know a lot of what causes it, but we do know it might be related to Candida or Pittosporum, but we're not for sure on that. So interventions you're going to want to teach the caregivers. Daily shampoos with a mild pH balance will help prevent it. Avoid vigorous scrubbing on the scalp. A topical steroid may be recommended for cases of severe cradle cap. You as a nurse would not want to recommend that. That needs to be a provider. And the reason for that is if parents or caregivers overuse it, it can cause the skin to thin out. It can also cause some whitening of the skin and cause issues if the baby is out in sun. So lots of liability for using corticosteroids on the head and face. So they do use it, but just remember, you don't want to recommend that as the nurse. Let that liability be on someone else. So if they're buying the anti-seborrheic shampoo and it's not getting better, then they really do need to see their provider. A really good, though, complementary and alternative therapy that you can recommend is to put warm olive oil or baby oil on the head, wait 15 minutes, and then shampoo the hair and brush gently. My daughter, my firstborn, had cradle cap, and that's what the provider told us to do, and it worked very, very well. Contact dermatitis. This is typically caused by an irritant or an allergy, and a lot of times when you don't know what it is, you can tell by how it's distributed. Like I said, poison ivy, poison oak, it may be on their hand or arm. Irritant contact dermatitis can have erythema, papules, vesicles, hives, burning, and weeping. You can have, the causes can be soaps and irritating chemicals. Allergic contact dermatitis is characterized by itching that's pretty severe, erythema, papules, vesicles, and streaks or patches. And common causes of this is poison oak, poison ivy, and poison sumac. Nickel found in buckles and jewelry can also be a problem. So of course, the first nursing intervention is avoid whatever's causing it. If it's poison oak, ivy, or sumac, you're going to educate them to wash the area thoroughly with soap and water. And this should be done within 15 minutes of exposure just to get those oils off of there. You're going to apply cool, wet compresses 4 times a day. There is something called Burroughs solution or Dom Burroughs solution that can be very helpful and can be used as a wet compress. You can use lotions and creams to help control itching, such as calamine lotion, Prax, Sama. Low dose over-the-counter corticosteroid cream, which is like your hydrocortisone, can be applied in a thin coat to relieve inflammation and itching. Like I said, just remember, don't put it on the face or the head. If the rash is extensive and involves the face or head, they really need to see their provider. Eczema, which is atopic dermatitis, can be, we know it's multifactorial in cause, so it can be genetic, environmental, so allergies or topical irritants, skin barrier dysfunction. It can be a hyperimmune activation of the T helper cells that result in the dry pruritic skin lesions. This typically involves the flexure surface of the extremities, so like your wrists, the neck, the area behind the ears, and sometimes the hands. As you can see on this little baby in the picture, it's right there where that foot flexes. Adolescent eczema is more common on the hands and in skin creases. Kids with eczema or atopic dermatitis are at risk for skin infections due to the underlying defects in the skin and breakdown of the skin barriers. Patients should be encouraged to avoid exposure to people with warts, herpes simplex, and other infectious skin diseases. You can do a culture if needed. You need to educate parents and caregivers on wearing loose cotton clothing, avoid wool clothing or blankets, use mild fragrance-free laundry detergents and fabric softeners. They need to wash all their new clothing before they can wear them. They need to have moisturizers at least 3 times a day. They need to bathe every other day in warm water and use very mild soaps such as Dove, Cetaphil, or Neutrogena. You want to make sure that they don't get the bath water too hot. They need to keep the environment cool and humidified. You may want to have them keep a journal and identify any foods or irritants that trigger eczema or make it worse. You want to try to prevent scratching, so you can use an oral antihistamine to help promote sleep and help that not itch as bad. Educate them to keep the kids' fingernails short. And you want to teach them how to apply topical steroids or immunomodulators as ordered. You want to carefully assess for signs and symptoms of infection, such as redness, swelling, pustules, or drainage. And some of the complementary and alternative therapies are vitamin A, which is 50,000 units daily, vitamin E, which is 400 units daily, zinc, 50 milligrams daily, omega-3 fatty acid, and evening primrose oil. You want to make sure and educate them not to go over the RDA, because they can get sick with some of the herbs and vitamins. And so the key to successful treatment of atopic dermatitis or eczema is hydration of the skin. Dry skin is a significant factor in the progression. So emollients, which is also moisturizers, are very effective. Some of the favorite ones, my favorite that I usually have patients do is Eucerin. They can also use Cetaphil, Aquaphor, petroleum jelly. But really, they need to be using that at the minimum 3 times a day, and right after bathing especially. You want to tell them that when they're drying off after the shower, the skin should be, sorry, I'm trying to get in the camera, patted dry and not rubbed dry. The 2 most effective medicines for eczema are topical steroids and immunomodulators. The topical steroids can be applied at the same time as the emollients. So the steroid cream is applied in a thin layer first, and then you put the emollient over the steroid cream. You can use occlusive dressing such as a plastic wrap or damp towel that may be placed over the steroid cream for 10 minutes to promote absorption. My son had eczema that was right behind where the ankle comes out when he was about 3 or 4, and we kept trying to use creams and it wasn't going away. So finally, we had a physician tell us, okay, you're going to use this cream and then you're going to wrap it in plastic wrap and leave it like your clean wrap in the kitchen. You're going to leave it on for 15 minutes, which now they say 10 minutes, but back then it was 15 minutes, and then take it off. And I'm telling you what, that just drives it in. And so it made a huge difference and immediately got rid of it. You can have topical immunomodulators when they're not responding to your regular run-of-the-mill corticosteroids, and that is medicines such as your tacrolimus or your pimecrolimus, which is like Elidel or Protopic. There are some black box warnings on there, and you want to make sure and educate them that they do not use occlusive dressings for this. And sometimes we do give them oral steroids if it's really bad. Acne. This is a common condition in older kids and adolescents. It's typically limited to once they start going through puberty, but significant lesions can result in long-term long-term scarring and social distress. Think of your body image deficit. Acne can be very manageable with multiple treatments, but it can also, think about this, because there's openings, it can cause the kid to get secondary infections. The primary lesions of acne is comedones or plugged sebaceous follicles. The problem in mild acne is not inflammation, but plugged follicles that produce open comedones, which is your blackheads, and closed comedones, which is your whiteheads. The bacterium and I'm not going to say this right, Propionibacterium acnes may produce inflammation in individuals with more severe acne. Inflammation leads to pustules, cysts, and scarring. Acne typically starts on the face, but can also occur on the chin, the chest, the back, the hands. So you want to educate them and their caregivers to avoid touching the face or squeezing comedones. They need to avoid oil-based creams or cosmetics. Makeup should all be oil-free. Teach your adolescent patients to read the labels. Teach your caregivers to read the labels. They need to clean their face gently 2 to 3 times a day with mild soaps, such as the Cetaphil, the Neutrogena. Harsh soaps and astringents can be damaging to the skin. They need to keep their hair clean and off the face. Think about your kids that don't like to wash their hair when they're that age and they kind of get the greasy hair. You do not want that when they've got acne. They may be prescribed topical comedolic agents such as tretinoin, azelaic acid. You want to administer topical antibiotics as ordered for mild inflammatory acne, such as your benzoyl peroxide, erythromycin, clindamycin ointment. Administer oral antibiotics as ordered, such as your minocycline or doxycycline. And sometimes they will do these antibiotics prophylactically if they have really bad acne, so they'll do a low dose every single day. You need to make sure your adolescents, if they're on birth control, you need to advise the secondary backup birth control. And I do find it interesting, we would tell them that they should not be eating greasy foods, they should not be eating chocolate, sodas, but now some of the latest studies coming out say that dietary changes do not affect acne. With all of the creams that are prescription that you use for acne, the patient and the caregiver needs to be educated to teach patients that they need to be using sunscreen, because all of the creams do make the skin more sensitive. And I talked about that black box warning on some of these ointments, but it can cause some skin cancer because of the changes. Combination oral contraceptives that contain both estrogen and progesterone have been shown to be effective in reducing acne lesions. And then spirulactone has also been found to be added. Bacterial infections is when you get a bacteria in those skin breakdown and it has an overgrowth. It can be by unintentional injury, it can be a surgical incision, but typically it's the normal skin flora just gets in those skin breakage. And a lot of times that's the staph or strep. However, any type of bacteria can be present. Impetigo, which is around the baby or the little kid's nose in the first picture, is a bacterial infection, and they get vesicles with a honey-colored crust. A lot of times you can also see it like around the corners of their mouth. Bullous impetigo is less common and only caused by staph. Bullous impetigo is more likely to occur in the diaper area of infants. And impetigo is extremely contagious and should be managed with topical or oral medications. But basically, in the clinical presentation, their papules turn to vesicles that crust over with a honey-colored crust. And remember, if they're itching, like if this kid itches his nose, or if it's on the mouth and itches it, and then itches his wherever, anywhere else, and there's skin breakage, it will spread. And they are contagious until they've been on antibiotics for 24 hours. So they should not be going to daycare or school until they've been on that for 24 hours. You want to educate caregivers, careful hand hygiene, contact isolation, given the topical antibiotics. Sometimes they do have oral antibiotics for extensive infections. You want to teach hand hygiene also to the kid. They want to keep the fingernails clean and trimmed to prevent scratching. They need to disinfect surfaces such as the sink, the bathtub, and toys. They need to wash the linens and child's clothes daily. Cover the lesions with loose cotton clothing if possible. Of course, on the nose, it's not going to be possible. But if it is, do. And if the infection gets worse or fails to resolve, they need to go back to see their provider. MRSA, methicillin-resistant Staphylococcus aureus, is caused by bacteria that's become resistant to common antibiotics used to treat staph infections. You can see this kid's neck right here where he's got a huge abscess. They are sometimes treated outpatient, sometimes treated inpatient, depending on where it's at and how bad it is. And because it is resistant, it is a lot more difficult to treat. It can easily be spread. So you're going to want to talk about good hand washing. But often it begins as a small red bump that can often look like a insect bite. And then it starts swelling. It gets more erythematous. It gets extremely painful. Now, one of the big things I like to remind you guys is early treatment on this, because when you start getting, like on that kid's neck, the boil, when you start getting a lot of pustule in there, it is acidic. So the lidocaine does not numb well. So it's extremely painful. You might see, which on this kid, they have a boil, but you can see a carbuncle, which is a cluster of boils, whereas just one boil is a furuncle or an abscess. It can cause some cellulitis when it spreads to the surrounding tissue. You do want to do a culture to see what kind of bacteria it is. Most often, though, these kids are going to have an IND, but like I said, it is painful. So if it's an infant or small child, you're going to want to get a papoose board. You're going to do wound dressings, antibiotics as ordered. And like I said, if it's very bad and has cellulitis, often they're put in the hospital. And these kiddos need to be on contact isolation protocols. Complications of severe infections may be pneumonia, meningitis, and osteomyelitis. You want to educate caregivers to keep the wound covered with sterile gauze and change as needed. Hand hygiene with soap for 30 seconds, not the hand sanitizer, but hand hygiene. They also need to make sure they're doing hand hygiene before and after changing the dressing. They need to disinfect their shower, bathtub, and any other surface used by the child. They need to complete their course of antibiotics. And they need to get medical help immediately for any signs of cellulitis that's getting worse instead of better. We will often draw a line around the redness so that if it's getting outside of the line, we know it's spreading. And I do recommend that because they don't spread all of a sudden, and it just slowly keeps growing outward, and often it can be difficult to tell. So put a line around it, and that way you know without a shadow of a doubt. If they colonize the infection, you can use nasal muprocin, which you just literally can put it on a Q-tip and swab the inside of each nair. And so when we talk about colonization in the MRSA, a lot of times they don't have any infection, but they carry the bacteria on them. They're more likely to have surgical site infections or pass the bacteria to other close contacts. They need to do careful hand hygiene and then do that nasal muprocin 2 to 3 times a day for a week. Bathing in chlorhexidine and bleach may prevent recurrent infections as well. And so some of the things that we do community-based to try to keep MRSA down, because it is resistant to so many antibiotics, is educating the patient when they come in with the virus that they're wanting the antibiotic, why we don't give them unnecessary antibiotics. We need to educate them that when we give them antibiotics that they need to complete the entire dose and not just 2 or 3 days. They feel better and stop, because that's contributing to MRSA. And then a lot of times they will do that so they can save the medicine for a later date. So we really want to have good antibiotic stewardship, and we want to educate our caregivers and patients. It's treated with vancomycin, linezolid, clindamycin, Bactrim, which is sulfamethoxazole, trimethoprim, and rifampin. So, we do suspect that we're going to start seeing some MRSA that is resistant to these, so careful monitoring. Liquid clindamycin is very bad tasting, so it's a lot of times hard for kids to take it. So we do recommend mixing it with a flavored syrup, and your pharmacy can do that. We already talked about the importance of good hand washing, but they need to not share towels or other personal equipment. Avoid line drying of clothes. Use a clothes dryer. And keep any wounds, boils, or sores covered. Disinfectants are used to clean surfaces such as shower and locker room benches that have contact with bare skin. Check the labels to make sure that it is effective against MRSA. Cellulitis, it develops when there's been a small break in the skin or recent trauma. It can often follow sinusitis or otitis media. However, it can occur in other things, just like we talked about MRSA. But we often see MRSA, staph, Haemophilus, or group A strep that causes it. The group A strep is common for strep throat and impetigo. And so on rare occasion, it can spread to the blood and then to the muscles or lungs. If it spreads to the soft tissues and muscles, it can cause necrotizing fasciitis. Signs and symptoms are redness, warmth, swelling, and tenderness. There can be lymphadenopathy and red streaking in the area. So again, mark it with that red pin so you can see, or mark it with that pin so that you can see if it's growing. They can also have fever, chills, malaise, and just not feeling well. You want to, if there's any drainage, you want to do a culture and sensitivity. You want to do blood cultures if they have any fever or signs and symptoms of systemic infection. You can get a CBC. your nursing interventions, you're going to want to assess the temperature, heart rate, respiratory rate, and blood pressure every 2 to 4 hours as needed. You're going to monitor the site for increasing redness, swelling, warmth, tenderness, drainage, or streaking. Assess perfusion. If you have a right here cellulitis, assess perfusing of the hand. So distally, make sure that you're still getting good perfusion down distal to that. And, you know, to check your perfusion, you're going to do your cap refill, you're going to do your blanching. Is it warm? Is it cold? What color is it? You're going to do a strict I&O on these patients. You're going to monitor their behavior and level of consciousness. You're going to put warm, wet compresses to the affected area. And warm, wet compresses is much better than dry, like a heating pad, just because the wetness kind of helps draw it out, the moisture. You're going to elevate the affected extremity or body part. They're going to be on contact isolation. And again, you want to educate on hand hygiene to everyone. You're going to give them Tylenol or ibuprofen as ordered for pain and fever. You're going to encourage oral fluids, and they're probably going to have some IV fluids going as well. They will also have some IV antibiotics, and you want to educate caregivers to seek medical help for increased fever or increasing redness, streaking, and pain. You want to educate them, of course, to complete the course of antibiotics. So here's a question. Purple or blue lesions that do not blanch suggest what? Do you guys remember that? Was it eczema, pressure ulcer, purpura, or cellulitis? So purple or blue lesions that do not blanch. The correct answer is C. Purple or blue lesions that do not blanch suggest purpura. And remember that this is a bad deal because this is telling us that the child has a critical condition, most often bacterial meningitis and or thrombocytopenia. Viral infections can be from common viruses that are spread through close contact. Some viral infections are self-limiting, where others can be lifelong. They typically have distinct patterns and should be treated appropriately based on what caused them. Papillomavirus, which is your HPV, human papillomavirus, and there are over 80 strands. Actually, there's more than that, strands or strains of the HPV virus. Remember that the ones that, you know, we automatically think of HPV in the genital area, but HPV causes warts anywhere. And typically, the ones that cause the genital warts do not cause the cancer. But we are seeing an uptick in oropharyngeal cancers from getting HPV in the throat, especially with adolescents. And think about it. How are they getting it? Oral sex. But it doesn't matter if they get HPV in that throat. It can cause oropharyngeal cancer. For kiddos, the most common types of warts are caused by HPV-2. And you know, families can get very upset about this. I personally saw a little girl, and this has been a few years ago, but I saw a little girl, her parents brought her in, and right where her labia folds were, above the clitoris, she had one wart. And by looking at it, you could tell that it was not a genital wart. It was a regular wart. She also had a wart on her thumb. Kids that age will often masturbate or play with themselves. And so I sent her on because, again, as primary care, it's not up for me to determine. Sent her on to a GYN. GYN removed it just to verify, and turns out it was from the little girl doing that to herself. So just because you see a wart down below does not mean they've been sexually abused. However, anytime that there is a potential for that, they do need to be checked. You can have plantar warts on the soles of the feet, and this is caused by HPV-1. Warts are contagious, so they need to perform hand hygiene. They need to be educated not to scratch or pick at them. Picking at them can cause a secondary bacterial infection and scarring. You don't want to share towels. Many warts do heal spontaneously and disappear without treatment in 2 to 3 years. However, if it's somewhere that's bothering the child or growing, they can do treatments such as liquid nitrogen, and this stimulates the body's immune system to help it fight against a papillovirus. They can do cryosurgery. They can do salicylic acid in the form of liquid gel or patches, which is also known as Duofilm. Kids who nail bite are at higher risk for development of warts under the nail, because think about it, you touch surfaces and the HPV virus can be on there and then they're, biting. HSV1 is the cold sores or fever blisters. One of the things I always like to tell you guys is you can get HSV1 in the genital area and you can get HSV2 in the oral area. So just because it's in the mouth or just because it's on the genital region does not mean that that's what kind of HSV it is. But you can get skin infections. It's endemic. Like 3/4 of the population has one of the forms of HSV. And remember that it often lays dormant and only comes out in periods of illness, fever, or high stress. And I often tell my patients that it's not just mental stress. It can be mental stress, but it can also be physiological stress. So maybe the kid hasn't been sleeping, or the kid's been really sick, or maybe the kid is in high school and it's finals time. So it can be anything like that. They're most contagious during outbreaks, but they can be spread without obvious lesions. Some of the medications, such as Valtrex or Valcyclovir, has shown because they decrease the amount of outbreaks, and so it also prevents shedding, they found. Remember, if infants get HSV1 or 2, it can be very serious. And it can go from the parents to the child with kissing or touching of the mouth. So it's important for you to educate caregivers on prevention and management. If they have a new baby, you want to educate them not to let people come around and kiss babies. Babies smell good. Babies are so cute. And you see all the old ladies holding them and kissing on them. Don't do that. Tell them not to do that. But the clinical presentation, as you can see in this lip, is small vesicles. It can be one, it can be multiple, but they are very painful. They leak clear fluid and may bleed slightly. The person is contagious for at least 1 week and sometimes longer after the infection. And transmission is typically direct contact or contact with toys that's been in the mouth. Systemic signs and symptoms include fever, irritability, and large lymph nodes. They're going to be on contact isolation in the hospital, careful hygiene, cool blame liquids because of the mouth is so sore. And sometimes if it's really bad, and I have seen this where they've had to have IV therapy or TPN, total parental nutrition, to keep them hydrated. You can also do, I told you about the Valtrex or Valcyclovir, which is PO. They do have IV acyclovir for severe cases. The education for the family is practicing good hand hygiene, don't share cups or utensils, sanitize the toys, avoid touching sores of the mouth. Prescription creams can provide relief and facilitate healing, and such as Abreva and Denavir. They can have oral acyclovir as well. You put cool water compresses to the lips. You want to use lip balm with sun blocking agents. And they can have some tetracaine cream that will help numb it. They can have what we call magic MMW, magic mouthwash. I had to think about that. Which has a teaspoon of Benadryl or diphenhydramine and a half a teaspoon of sodium bicarbonate. This soothes it, but they need to be educated not to swallow it. They need to swish their mouth and then spit it out. And sometimes you'll see some of this magic mouthwash with some topical lidocaine in it. Not the ointment. There's some that you can swish. But remember that that is going to numb their gag reflex. So if they're taking that, then they need to make sure that they're not eating or drinking until that gag reflex comes back. Tinea, fungal infection. These can be multiple areas throughout the body, and the name will tell you where it's at on the body. It commonly occurs in warm, moist environments or close contact with pets or other individuals with tinea, such as locker rooms, showers. So you have a lot of people that if they have to use a community shower, whether they're in sports or military or whatever the case may be, camping, they use shower shoes. And a lot of times, these have to be treated for long periods to eradicate the infection. Tinea is spread by direct contact, contact with personal items, in some cases by pets. So on this, I think that's a foot. I can't tell 100% by this picture, but I think that's a foot. But you can see in that picture, one of the telltale signs of tinea is, see how it has that demarcated line around it? You don't see that in any of your other rashes. And we'll talk about Lyme's disease in a minute, but even that looks completely different. So if you've got a well-demarcated area like this with a circular lesion, it does have raised edges and central clearing. It's almost always tinea. Itching is common. Tinea corporus, which is your ringworm. So a lot of times you get it on your arms or your legs, but you can get it anywhere. Tinea capitis, which is on the scalp. And these are circular patches with scaling and erythema. But again, it's going to look like that picture there. It's just on the scalp. They can have hair loss or broken hair. Tinea pedis, which is the foot, or commonly known as athlete's foot, and it's very common in adolescence. Lesions can be scaly or made up of vesicles and pustules. Pustules, I can't talk today. Itching is common. Tinea crus is a fungal infection of the groin, or also known as jock itch, most common in adolescent males. There are scaling patches in the folds of the groin and upper thighs, and again, they have that demarcated sharp edge. Itching can be intense. Diagnostic: if you have a woods lamp, that will cause tinea to fluoresce and show as green. On occasion, there are a couple of types of fungi that doesn't turn colors under a wood lamp, but you can scrape the lesions, and the tissue can be mixed with potassium hydroxide, so KOH, before examining under a microscope. If fungi are present under the microscope, branching strands or the hyphae can be seen under the microscope. Education for the caregivers and the patient is apply antifungal creams such as miconazole to the lesion twice a day. If lesions are moist, such as in the groin or between toes, apply wet compresses using Burroughs solution twice daily to dry the area. They need to not share hats, combs, brushes, ribbons, scarves, clothing, or bedding. They should cover any skin lesions. For athlete's foot, air dry and keep those feet open to air as much as possible to allow it to draw out. Change socks daily and alternate shoes to give them a chance to air out. For tinea capitis, which is again on that scalp, you're going to shampoo the hair twice daily for 2 weeks with shampoos such as selenium sulfide or ketoconazole. Shampoos are effective in mild cases, but occasionally we do have to do oral medication. And oral medication is griselfulvin, and it's given once or twice a day for 4 to 6 weeks. We also will do that if they have toenail fungus that is really bad. They have to take this medicine with high-fat foods such as ice cream or peanut butter to enhance absorption. Side effects can be nausea and sensitivity to the sun, so they need to make sure and be educated to wear lots and lots of sunscreen and avoid sun. Kids must be reevaluated monthly, and they must have labs because it is hard on the kidneys and the liver. But it is approved in kids 2 years and older. So insects and bugs, the dreaded head lice. And remember, head lice can jump, and it spread from one person to the next with sharing items of direct contact, resulting in outbreaks in schools, healthcare facilities, shelters, and daycare. It can cause extreme itching. It can cause some erythema, edema, and skin breakdown. Pediculosis is head lice. So the clinical presentation is nits or lice eggs, and they are very small, white, translucent, or yellow dots that are firmly attached to the base of the hair shaft. Nits hatch in 7 to 10 days. An adult louse is approximately the size and shape of a sesame seed. Lice feed on blood from the scalp and cannot live more than 48 hours away from the scalp. Now, you will see black lice, and the reason you get black lice is because that's lice that's already been feeding on blood. And so the blood, they're normally white, and once they start feeding on the blood, then that's what makes them turn a dark color. Now, I have people that ask, well, how do you tell the difference between dandruff and lice? If you have some hair and you see some white in there, if you move the hair and it just flakes off, that's dandruff. A nit will be attached to the hair follicle, and you literally have to pull off before it's going to go. It's not just going to fall off. You're going to want to examine the hair under a bright light. A magnifying glass and fine-tooth comb can be helpful, and it's helpful to divide the hair into sections and examine one section or strand at a time. Nits are usually found within 1/4 of an inch of the base of the hair shaft. You're going to give them a shampoo to hair that's been shampooed and towel dry. Nix or permethrin, 1% is the most common, but there's also rid, clear lice, pronto. And you're going to educate them. They need to leave it. They put it on the hair, they leave it for 10 minutes, and then they rinse it off. And then they need to repeat the treatment in 7 to 10 days. They need to get those nits out of there, so use a fine-tooth comb, because otherwise, if those nits hatch, they can get reinfested. You can also use ivermectin lotion for kids 6 months and older. After you use the comb to get the nits out, you either want to put it in one of the shampoos for 15 minutes that we just talked about, or just throw it away. You need to educate the caregiver to wash clothing and bedding in a hot soapy water and dry on hot cycle. They need to dry clean items that can't be washed. They need to vacuum the floor, the mattresses, soft stuff furniture. Sorry about that. Scabies, I didn't get to go over, but a lot of times you can see the tracking of the skin. So if you see a little tunnel, that's usually scabies because they burrow down into the skin. Most often you see them in the hands and around the fingers. Lacerations, very common for these kids, and they can result from intentional or non-intentional injuries. So think about intentional as like surgical. Unintentional is the injury. You want to make sure and document the size and location, what type of material broke the skin, and whether there are foreign objects in the skin. For instance, were they in a car accident? They've got some gravel inside or dirt. You're going to want to assess for bleeding, assess the neurovascular status of the extremity involved. And then you're going to want to do wound dressings as ordered. Bites, the mouth is dirty. Because it's warm and moist, it harbors a lot of bacteria. So bite wounds from animals or humans can be very traumatic. They're difficult to clean. So we almost always will do prophylactic antibiotics to those. You want to make sure and do dressing changes. If they're at home, they need to wash and dry it immediately with warm soap. And remember, if it's a bad, that you think they may need stitches, we can't suture it if it's more than 8 hours old. And that's because the chances of it getting infected are significant. Again, you're going to provide emotional support. You're going to report it. Any kind of a bite is a reportable thing to the local law enforcement as well as the CDC. You're going to teach caregivers to watch for signs of cellulitis or localized infections, such as like your erythema, warmth, red streaking, edema, purulent drainage, fever, and increased pain. Good hand hygiene. If it's a bite from an animal, you want to know if they've had their rabies vaccinations, if it's up to date. Sunburns are a result of prolonged or intense exposure to the sun's UV rays. It can be from mild redness and inflammation to severe blisters and peeling. There is such a thing called sunburn poisoning. Burns, as you can see here, there is a chart. You should always calculate up what the burn is. Most burns are preventable, and we're going to talk about it a little bit more on the next slide. Superficial epidermis is red, painful, no blistering. Superficial partial thickness epidermis is red, painful, blisters, moist, and weeping, and it does blanch with pressure. Deep partial thickness is dry and white, red with blisters if the burn was caused by scalding. Less pain because it's so deep, it often damages those nerve endings. Full thickness has absolutely no pain, no blanching, has a white or charred appearance. For these kiddos that are severe, you're going to do ABGs, arterial blood gases, to make sure that the respiratory involvement is okay. You're going to do a carboxyhemoglobin level, which checks for carbon monoxide poisoning if the child was in a confined space. EKG or cardiac monitoring if it's a severe burn or electrical burn. Wound cultures, and burns are hard, guys. And a lot of times burn units with the debridement, it's some serious stuff. You make sure the kid's tetanus is up to date. You need to provide pain medicine as needed. And if you have a kid that's getting ready to be debrided, make sure you give them their pain medicine in plenty of time. Even if they don't complain of pain, give them their pain medicine before they have that debridement because it is horribly painful. Kids that are in house fires, you do want to look around the nose to see if there's any soot there, because if there's soot there, it often means that it's got down into the lungs. So I wanted to talk a little bit about this. So see the little kid reaching up on the pan? When we have burns in kids, it can be caused by two different causes. Accidental, and you can usually tell by the accidental. So think about the kid reaching up for the pan, and then the little kid on the right-hand side, you see how it's, you can tell how that liquid just came right straight down him. just right down in that area. You can tell that was an accident. Caregivers need to be educated on prevention. Now, this is your pediatric physical abuse. We call these immersion, and that's where parents will physically take their child and put them down in hot scalding water. Now, the difference in that, you see that little kid's legs, that has a even demarcated line. So again, you put them straight down in there. The other things that we can see in intentional kid burns, do you see how in that first picture, like they're holding this baby down on the bottom of the tub? Well, guess what? The bottom of the behind is on the tub floor, so it gets spared. So see in the second picture how the bottom of the behind gets spared. Also, it has what they call striping because of how the skin is whenever they're put them down. But this baby in that first picture is going to have that demarcated line all the way across because of that immersion. Now remember, anytime that you have any suspicion, you need to report it. It is not up to you to determine if it is child abuse or it is not child abuse. That's up to the authorities and people that specialize in forensics and do that type of thing. It is up to you to report your suspicions. What is the appropriate weight for the use of an EpiPen? Over 30 kilograms, under 30 kilograms, under 20 kilograms, or any weight? Use for EpiPen for children is over 30 kilograms, but they do have an EpiPen Junior for children under 30 kilograms. And that goes right into our topic of allergic dermatitis and anytime they can have an allergic reaction. All right, well, I hope you all have a wonderful day, and if I can be of any assistance, just let me know.